just two dudes talking, okay? So with that being said, she says, a question about statins. Can you just stop taking your statin? Do you have to wean down the statin? Is it safe to stop it, etc.? Yeah, yeah, okay. Thanks for raising the question. Awesome.
I would probably ask a few more questions. Why are they on the statin to begin with? Is it just because their cholesterol number was high? Did he have, an MI? Does he have a stent? So I think you really have to put it into the context of why you were started on it. I know in the South, I saw some people who were like 13 years old on a statin. 13-year-old girls on a statin. And I asked, why are you on a statin? She said, oh, my cholesterol was high. So I think you have to really kind of ask a few more questions. So let's say, hypothetically, you're just put on it because your cholesterol is high, and you haven't had any heart disease or anything like that. Then the second question would be, well, have you had the NMR lipid profile that I asked about, or I talked about earlier? Because then that's going to give you a little bit more in depth in terms of, do you have the profile that's going to be more likely to cause cardiovascular disease? As far as stopping it, I would say 99.9% of people should stop it. Hands down. Get into that. If you look at the studies, the people should likely stay on the statin. But even then, you can adjust the dose of the statin. So a lot of times, some of the side effects, the common side effects, the nausea, the muscle aches, the liver enzyme, are because we're pushing massive doses. So just a little bit of historical background, and Ken can probably talk about this. Also, we have been pushing the number, the total cholesterol, the LDL hypothesis down to the point where we pushed it so far down, meaning we want your LDL to be less than 200, then we want it to be less than 150, then less than 100, then less than 70, to the point that it was just impossible for most people to get there. And so they would push the number of statins that you would take, or the dose, higher and higher and higher. And as you push the envelope in terms of how much statin you're asking people to take, the side effects really start creeping up. People who have had a heart attack, old white men, likely will benefit. But otherwise, I would stop it. Risk of diabetes goes up. Risk of dementia goes up. Risk of side effects, meaning muscle aches. Let's say you're an old white lady or an old female who is on a statin, has weak muscles, falls, breaks your hip. In that context, being on a statin is probably not the smartest thing for them to be on. So, and in terms of the mechanism of action of why statins work, part of it is really the anti-inflammatory properties of it. So we put people on a statin if they've had an MI or they've been put on a stent. But a lot of the benefit from it is not the cholesterol property, it's the actual anti-inflammatory property. And you can get that by other means.
Yeah, great information there. I would also add that statins lower your testosterone. A lot of guys don't realize that. As we talked about earlier, testosterone levels being optimal, you want that if you're a man or a woman. And so if you're taking a statin, the statin blocks the cholesterol hormone cascade at a certain point. And without cholesterol, you can't make testosterone. Your body just can't make it. And so you de facto lower your testosterone if you're on a statin. And so a few weeks back, I'm not sure how long ago, I posted a review article on our Facebook page that looks at all the research. And based on that research study and other studies that I've looked at, unless you are an elderly Caucasian male who's had previous heart attack, you don't need a statin. Okay, there is no wean down process of statins. The way you wean them down is to throw them in the garbage. Okay, there is zero evidence that a woman needs to lower her cholesterol. All the research, when you look at it objectively, shows that women with high cholesterol live longer. They have less all-cause mortality. So if you're a female over 50, you want your cholesterol to be 220, 230, 250. You want that. That's good. And for men, it appears to be either background noise or also protective. It's not as clear cut in men, but in women, you absolutely want your cholesterol to be a little high. Looks like the same goes for LDL cholesterol as well in women. And that may be true in men, maybe not. We don't know yet. I don't feel like we have enough research to know that definitively. But unless you are an elderly white male who's had a previous heart attack, you do not need a statin. Well, because we're taught that, I mean, that is the du jour pill right now. That is, everybody wants your cholesterol and your LDL to be super low. And the new class of drugs like Repatha, I mean, they bottom your LDL out to what I think would be a dangerous level. And so that's how all med students and doctors have been taught over the last 20 years, is that cholesterol is the number one enemy. Doctors don't care much about your A1C or your insulin metabolism. They don't care much about your hormones, don't care much at all about your hormones, but they want that total cholesterol and LDL to be low. And that's all they care about. I've had multiple patients come to me with an A1C of 8. And their doctor didn't even really want to discuss that, but their total cholesterol was 202, and by George, they were either going to be on a statin or he was going to discharge them from his practice, fire them as a patient, but didn't even want to talk about the A1C of 8. So go figure.
And they're not talking about numbers needed to treat.
Right.
Explain that.
The only other thing I would add to that is, I think it's in 2004, 2005, around then, the premise that cholesterol causes cardiovascular disease was essentially set in stone. So there are no more studies looking to see if that idea is true or not. It's now a medical fact. All the clinical studies are looking at the new drugs versus the old drugs, or the new drugs versus placebo, to see how that impacts the cholesterol. So I don't think we're going to have any studies coming forward that is going to challenge that premise that cholesterol causes cardiovascular disease.
Does that make sense? And so now the study would be, oh, my new drug, stupid statin, we're going to compare it with ignorant statin. And then that's the study. So it's taken for granted that high cholesterol increases your risk of heart attack. That's not even up for debate anymore, so it's not studied. There are no new studies looking at that with fresh eyes, although there should be. Who's next? Yes, ma'am.
The LDL number, what should we use? Is that 220 to 252?
Yeah, when I order a lipid panel on a patient, I look for low triglycerides and I look for high HDL, and I don't care really what your LDL or your total cholesterol is unless it's very low. And more and more, the more I listen to Dave Feldman and Siobhan Huggins, the more I worry that if a woman has a very low total cholesterol, that might be a sign of underlying disease that I need to look for. And so I really don't care if your total cholesterol is 220 or 250. I don't care if your LDL is a little high or a lot high. I think if you're a fat burner, you have to transport that fat for it to be burned, right? And so if you're doing Stairmaster in the gym, how do your calf muscles and thigh muscles, how do they get the fat to burn? You have to transport that. And how do you transport it? How is it transported, right? You have to get it there, and it has to travel through your blood. And so if you're a fat burner and you're fat adapted, I see it as more common than not that you're going to have an elevated total cholesterol and an elevated LDL. By our current standards, they would call them high, but I would call them optimal.
The only thing I would add on that is, I kind of mentioned this in my talk a little bit, where LDL is really referring, so there's LDL, and the NMR lipid profile is going to break it down into terms of LDL-C and LDL-P. So LDL-C is going to refer to the cholesterol content of that particle. LDL is a lipoprotein. It's basically the ship that takes the energy to the cells to be used for burning. The LDL-P is the number of ships that are being used. So what Dr. Berry is referring to is those numbers are important in the sense that it tells you how much energy is being delivered to the cells to be used for energy. Well, the number that is really important is the triglyceride, because the triglyceride is that energy molecule. And so if you have very, very low triglycerides, that means it's being used for energy. If you have very, very high levels of triglycerides, that means that is not being used for energy. You are using glucose mostly for energy. And so if you keep it in that context, it'll make a little bit more sense in terms of what numbers you're looking at. So get the NMR lipid profile. It's going to give you a better idea of what type of LDL particles are you having. Are you having the very, very small ones that are atherogenic, meaning they're the ones that are pro-inflammatory, are going to cause issues with the blood vessels? Are you having the big fluffy ones that are essentially derived from eating fat, from eating keto, that are not going to cause the damage to your blood vessels?
Let's have a stand up to ask questions so that we can see and hear you better.
So our doctor says for us, when we're interpreting lab results, we're looking to the ratio of triglycerides and HDL, that number should be less than 3.8. How can I talk to my patients about that, and get them to understand that total cholesterol is not significant? How can I break that down to them that they don't need to be stressed out?
More and more of my patients in the clinic know that I don't care about total cholesterol, and so they're happy to not worry about that. The few patients I still have who are worried about that, I print them out a copy of the review article that I talked about earlier that's on our Facebook page, and I just tell them total cholesterol is not a lab result of concern. I don't care about that. What I care about are the independent risk factors that have been verified, because what I'm trying to help my patient do is live long and happy and not have a heart attack or a stroke, right? And the way I'm going to do that is to keep your triglycerides very low, your HDL very high, and all the other markers of metabolic syndrome, I'm going to try to keep those optimized. And there's 5 markers for metabolic syndrome, and total cholesterol is not one of them. So I don't care about that.
I'm just going to repeat the question real fast. So the question was really looking at the HDL to triglyceride ratio as a marker of cardiovascular disease. Because again, we're talking about cardiovascular disease because it's the #1 killer in the United States and essentially worldwide. I actually print out the Framingham heart study that looks at specifically those numbers. So there is a couple tables there that will look at different numbers in terms of the HDL, LDL, triglyceride, and mortality. And if you look at them, we keep telling people that we need to push the LDL down as much as possible, right? Well, if you look at all-cause mortality and mortality from heart disease, there is essentially no difference depending on the LDL number. There is a difference in terms of triglycerides, and that's the most striking one. And so that's the biggest study that we have to date in terms of looking at heart disease. So I think that's usually pretty powerful, and obviously explaining what it means, but yeah.
So I believe I have to, when I consider my cholesterol.
Stand up real loud.
I'm sorry, when I consider my cholesterol, it's the triglycerides I have to really look at, and not the.
If you're looking at a traditional cholesterol panel, I would say triglycerides are extremely important. HDL is still important. I think the point that we're trying to make is that you have to go beyond just the total cholesterol number because it doesn't necessarily give us much information.
Yeah, because that was what I was told was there, the other.
Right.
Thank you.
There are still many doctors out there practicing who have no idea that the total cholesterol has been considered meaningless by doctors for about a decade, 15 years now. A doctor who's up to date on his reading knows that total cholesterol is meaningless as a risk factor for heart attack and stroke. It's just meaningless. Now LDL, that has not been known for nearly as long. But yeah, if your doctor's still worried about your total cholesterol, he's way behind in his reading.
Well, there's even been studies that have shown that patients who come into a hospital setting who have a heart attack or some kind of cardiovascular event, 3/4 of them had normal or better cholesterol.
Yeah.
So if it was high cholesterol, you would think the people, it would just be overwhelmed.
You think it'd be skewed that the people with acute myocardial infarction would tend to have high cholesterol, but that's not the case. Some studies show 50-50. Some have normal, some have high. Other studies show that even more than that have low cholesterol, but they still had a heart attack. Yes,
I'm looking to just expand on the physicians that are kind of not on board. A lot of the patients that I'm kind of dealing with are scared to tell their physicians. Is there any way, do you have them print out that same review? Ideally in a non-confrontational way to get the physician to open up their mind into conversation. Working together is obviously better than not working together. So how do you propose, and in your dealings with other physicians, what has worked best in a kind of simplistic way to get them to open their minds up to that transition?
so the question is, how can a patient whose doctor recommends a statin, how can they approach that subject with their doctor and say, hey, I don't want to take a statin? Okay.
Or even if their panel comes back and their triglycerides are way low, but their total is way high, and the physician panics, which has happened several times, and I'm sure it's happened to people in this room.
Yeah, and I have patients who travel some distance to see me, and often they have primary care back in their hometown, and I'll print off the review stuff and say, take this to your doctor, and don't expect him to read it right then, he's busy. But say, hey, I want you to look over this, and I'm gonna come back in a couple of weeks, and I wanna have a conversation with you about this, because I've been told that I need to worry about my triglycerides and my HDL, and I don't need to worry about total cholesterol. That's been known for years not to be a risk factor for heart attack and stroke. And so I'll tell people to do that because I want everybody to have a learned health partner. You need that, I think. And so then also a lot of patients will just take the prescription and smile and nod and toss it on the way out the door. Other patients, doctors will call and check, see if they fill the statin, and so they'll fill it and then they'll toss that. That's a strategy that some people use, just so that their doctor doesn't get mad at them.
I just ignore the doctor.
Now,
That's all.
in my situation, I would never suggest that you ignore your
No,
primary
I'm kidding.
care.
As I mentioned earlier, I think one of the greatest assets we have is there is so much information out there now. And I think the way that we're going to really change the paradigm is by taking some of the information that's out there and using some of the more relevant studies that doctors will actually appreciate. So the way that doctors think, the way that we're taught is essentially by looking at research studies. And the most powerful is going to be randomized controlled trials. After that, it kind of goes down into a cascade depending on what kind of doctor you are. Some really like the epidemiological studies because it proves their point. But that's the way that they're going to be kind of trained, is to say, well, what did the randomized controlled trial show? And so if you can take some of the more relevant studies that really reflect that LDL in and of itself is not a significant risk factor for cardiovascular disease and bring that to them, if they are willing to read it, then you can have a good partnership and a good discussion. If they're not willing to read it, then I think you have to make a personal decision and say, hey, anybody around here have a good doctor who's willing to be open and discuss this? Because at the end of the day, we're talking about your health. We're talking about everybody's health here. And that obviously is more important than having a doctor relationship, I think.
There's a great website, by the way, spacedoc.com. Dr. Dwayne Bradley, he passed away last year. He had some complications from taking statin medications, but lots of studies, lots of free information on there if you want to geek out on lipids.
Both of you have mentioned sex hormone testing, so and bioidentical hormone. So I wondered about risks and benefits of hormones, and I've heard that there are risks.
Yeah, the question was about sex hormone testing and then also replacement. Is there any risk relative to benefit? It depends on male, female, obviously, to begin with. I'll start with female, and then maybe you want to talk about males. So from a female standpoint, obviously, ARC is preventative initially. And so how can you prevent getting into perimenopause, menopause at an earlier stage. A lot of that is this imbalance of hormones that are being produced. I think in the first or second day I mentioned that as you have more kind of truncal obesity, those adipose tissues, those fat cells are very metabolically active, meaning that they're converting a lot of the estrogen into testosterone. And so you're getting an imbalance of those two. And the flip side for men is a lot of the testosterone is being converted to estrogen by the aromatase enzyme. And so they're getting more feminized. So initially, I think testing is important. And then trying to do something in terms of dietary changes, lifestyle changes, to see if you can get back into balance. Do you have a specific question in terms of which hormones to check? Or just in terms of, let's say we've done all that and it's not working and now you're concerned about starting bioidentical hormone therapy?
Whether or not that's a risk.
Yeah.
Post-menopausal.
So in terms of the risk benefit, in anything that we do, there is a risk benefit, right? So you have to kind of weigh the two. There's a difference between bioidentical hormone replacement and then just hormone replacement, meaning something that is manufactured that is not identical to what you normally produce. So I would be in the camp that says you should not take something that is not normal to your body. I would say that you probably agree with that. But then when you're looking more at the bioidentical hormone, as we mentioned earlier, if you have low vitamin D levels, you have increased risk of cardiovascular disease. Men with low levels of testosterone have an increased risk of cardiovascular disease. There is fear out there because I think some of the kind of media will say, here's a study, it's a case study, or it's an observational study, and these people took testosterone and they had a heart attack. And so A equals B. Where the reality is that replacement with bioidentical hormones, I think, is extremely healthy as long as you're maintaining it in a ratio that is normal. If you are taking it to basically ramp up hormones to an extreme level, then I think obviously you're going to have many side effects. So from my perspective, I would say it's beneficial.
So, yeah, I totally agree with that. Two things. First of all, there are testosterone receptors on your heart muscle. Okay? Now think about that for a second. Why are they there? When you optimize somebody's testosterone, men or women, and by optimize, I don't mean make them up there like Lyle Alzado. Remember him, right? I'm not talking about crazy NFL player levels of hormones. I'm talking about put it in upper level normal, like it was when you were 25, when you were 20, when you were 30. Then your cardiac output is improved. There are studies that show that. Okay, and so I'm fortunate to practice near St. Thomas Hospital in Nashville, which is one of the top 10 heart hospitals in the country. And all the cardiologists there love it that my patients have normal testosterones because they know that that decreases their risk of cardiac events. Okay, if having high normal testosterone levels were dangerous, then when you were a senior in high school, you would have been at very high risk of a heart attack, stroke, prostate cancer, breast cancer, right? If real testosterone, real progesterone, and real estrogen were risk factors of cancer, how many people your senior year of high school had a girlfriend who had breast cancer or ovarian cancer or nobody, no heart attacks, but everybody's hormones were sky high your senior year in high school, right? So there's this study they did, I forget what year it was published, called the Women's Health Initiative. And there was an arm of that study that was studying hormone replacement because there for a minute they thought it was very protective against cardiovascular disease. And they had to stop that arm of the study early because these women were having severe complications. But that was not, and so every doctor will say, well, see, that shows you that estrogen replacement is bad. Okay, first of all, were they using real estrogen in the study? They were using conjugated estrogens, okay? If I took the actual estrogen molecule, could I take that and get a patent on it? Can you patent water? No, you can't patent normal, natural occurring molecules. They had to tweak that. They conjugated it, okay? That makes it a unique molecule. That also makes it not estrogen anymore. It's estrogen-like. And so Premarin, Prempro, estradiol, they're all estrogen-like. And they fit pretty good in the estrogen receptor and activate it pretty good. But they also, it's proven without doubt, they increase your risk of cancer. No doubt about that. That's why they stopped that arm of the Women's Health Initiative study early. But real hormones, real testosterone, real progesterone, real estrogen have never been shown to increase anyone's risk of cancer. Okay. And if any men are in the room are worried about testosterone optimization, there's a great book by Morgenthau about testosterone. He's a Harvard professor. And the original problem with testosterone was started by a Harvard professor who, based on his research on 2 or 3 people, said, oh, it's like pouring gasoline on fire as far as prostate cancer. No research, no RCT, just his opinion. And since he was from Harvard, everybody just jumped on board and said, yep, that's it. There you go. There's the truth of the matter. And so, but when you go back and actually look at the research, real hormones, there's essentially no risk unless you're putting that level super therapeutic above normal range, right? But to optimize your hormones, I think is exceedingly safe and exceedingly healthy.
What's that testosterone food hormone?
It's got the word testosterone in the title, and his name is Morgenthau, and that's all I can tell you. Yes, ma'am.
Where do you find bioidentical estrogen and testosterone? Because a lot of these doctors are wanting to prescribe the estradiol to replace estrogen. So how do you get your hands on the bioidentical stuff?
So how do you find a doctor who will prescribe bioidentical hormones if you need them? And that's a great question. First of all, let me be clear. I'm afraid I wasn't clear enough. No human in this room or anywhere needs to take Premarin or Prempro or estradiol. They are fake estrogens and fake progesterones. There's another one called Estratest, which has fake estrogen and fake testosterone. It's methyl testosterone, and a few years back, they took that off the market for men because they found out it was damaging their liver. Now, hear me. It's still on the market for women. It's called Estratest, but it's dangerous for men. But you women, you'll be fine, I'm sure. True story. Not joking. And so, any hormone you get like that in a pill form is dangerous. Don't take that. So, with that being said, a good strategy, there's 2 strategies I'll tell you, and John may know another. If you'll go to a compounding pharmacy, and that's the old-fashioned kind of pharmacy, they usually have the mortar and pestle on the sign. It's usually a mom and pop level store. It's not a chain. And ask him, hey, who does bioidentical hormones? He'll know because he compounds the prescriptions. Second way to do it is to Google bioidentical hormone optimization and then the name of the largest city near you. Right, Chicago, Miami, LA, whatever. And because any big city is going to have anywhere from 1 to 20 docs who do bioidentical hormone optimization. I do them in Camden, but that might be quite a drive for some of you guys. But those are 2 great strategies to find a doc who does them.
Yeah, I would agree with that.
I just want to go back to the basic keto diet for just a second, or keto lifestyle. In the clinic that we are in, we are seeing people that are on one hand relatively healthy, 30s, 40s, trying to work on really truly obesity weight issue. On the other hand, we're seeing some older adults with a lot of chronic problems and a lot of cardiovascular disease. So one of the things that in the very beginning of our group that we are doing, we actually almost read this thing that almost makes keto sound like, you might die if you do this, but just we're not responsible. I mean, there's a thing that we're reading now. What I'm trying to ask you is this: for the people, we have somebody who is diabetic, and under the care of our dietary physician, he is bringing people off their insulin to do strictly keto. He's trying to stop all those medicines. And we did have somebody who actually did have a little incident that was somehow she did get the message about some of the things he told her. So there's been a little bit more fear introduced, into the equation. My question question is basically about people who now, not that we're trying to prevent cardiovascular disease, people who have cardiovascular disease, people who haven't bypassed yet, but they're on stent. And then trying to talk to those cardiologists where you just talked about statins. When I raised that to a cardiologist recently, that cardiologist looked at me and said, okay, here's the deal. This is truly what these studies say. Statins may not lower that cholesterol or the bad cholesterol or LDL or the particle cholesterol so significantly, but it cuts mortality in half. And that's the reason why we're keeping these people on statins, is because of that. So with all of that, I guess what I'm trying to ask you is this. There's still an account of eat the Mediterranean diet. That's what's being said. Don't eat, do lower carb, but just, eat the Mediterranean diet. How do you begin to talk to cardiologists with patients who have stents or patients who are, who are truly cardiovascular patients? We're not trying to prevent it, we're there to try to get them to this viewpoint.
Okay, I'm not gonna repeat that. But basic question is people who already have heart disease, metabolic syndrome, and you're having a discussion with the cardiologist regarding going keto versus taking a statin, essentially.
Yeah.
Have you been to the Mediterranean? You personally? Anybody been to the Mediterranean? Okay. Where'd you guys go? So I've been all over the Mediterranean. I don't know how many countries there are, but I always find it funny when you talk about the Mediterranean diet because each country is extremely different. And so they say Mediterranean diet, I don't know which part of the Mediterranean they're talking about. But essentially what they're talking about is, using more of olive oil, monounsaturated, polyunsaturated fats versus saturated fats. The second thing that you mentioned is mortality. By taking a statin, you're going to decrease mortality by 50%. There's a couple things that I think is important to mention, and those are absolute risk versus relative risk. One of the biggest marketing strategies by a lot of medications or pharmaceuticals is this idea of mortality risk. So if you take this pill, your chances of getting a heart attack go down by 50%. What they don't tell you, because it doesn't really sell in terms of advertisement or make big headlines, is that that risk went from 1% to 0.5%. So from an absolute perspective, you dropped your risk by 0.5%. Right, not 50%. The second thing is the number needed to treat. So how many people do you have to give this medication to in order to have one outcome? And you never hear that term, ever. Next time a cardiologist asks you or says that to you, I would ask them, well, what's the number needed to treat? Just make sure you don't want to make enemies. But the point that I'm trying to make is that there is obviously a big financial perspective in this, in that we are basically paying for pharmaceuticals to give us medications versus preventing disease by changing your diet and lifestyle. There's not much money to be made from that, right? There's, what can I sell you? What pill can I give you? Exactly. So to answer your question, my way of approaching it is to have an honest discussion. There are studies that are looking specifically at cardiovascular disease, people who already have cardiovascular disease and go on a ketogenic diet. You can measure that. You can do things like a cardiac calcium test, looking at what is the actual calcium in the coronary arteries. You can look and see, okay, well, if I do a ketogenic diet, I decrease the inflammation, what happens to that score? Does it get better? Does it get worse? You can do another test, which is looking at the thickness of the arteries in the neck. I would advise most people here to do that now. Do those two tests now.
CT heart scan and CI and T.
Yeah. Because then you're going to have a baseline so that when you do keto, all your lab markers get amazingly better. You lose weight and your cholesterol goes up by 30 points and they want to put you on a statin. You can say, here's what happened to the thickness of my arteries. Because if that thickness is getting better, chance of you having a heart attack goes way down, having a stroke goes way down. And that to me is a lot more important than a absolute risk reduction of 0.05% or 0.5%.
Can we clarify the numbers needed to treat things? Because what that is, you guys, is for every 100 patients they put on statin medication, one sees benefit, and it's screw you to the other 99 that may have some side effects. So it's huge.
Absolutely. And one thing I would add to tell your patients, and so I'm happy to have a compromise with the cardiologist. And so if he is adamant that this patient needs to be on a statin, then if the patient's having any side effects of the statin, 40 milligrams of Lipitor, for example, right? I'll lower their Lipitor to 5 milligrams. And I'll still have them eat keto, right? And so then when they go back for their follow-up, they can say, yeah, I'm still taking the Lipitor. I was having bad side effects, so Barry lowered the dose, but I'm still taking it. I'd much prefer somebody be on 5 of Lipitor versus 40, right? Yeah, or Crestor, exactly. And so, and then they can still eat keto. Keto is the natural diet we should all eat. And so whether you have heart disease or not, you should still eat the vegan diet, shouldn't you? Right. So yeah, and so a lot of heart doctors have just heard about keto, so it sounds like some kind of weird fad, weird thing, right? And they haven't thought it through yet, and so you'll have to be just quietly educating your patients and lowering the statins. So they're still, and I have so many patients who are still spooky about that, and so they're on 5 milligrams of Lipitor. I'm happy to make that compromise. If that's if they still need that statin, then that's fine. I'll give them 5 milligrams, and there you go. And then eat keto. Yeah. Yes, ma'am.
Are we risking permanent metabolic damage if you're doing one meal a day and it's averaging between 800 and 1,000 calories?
So is someone risking metabolic damage, like a permanent damage to your metabolism if you're eating one meal a day or not? And I would say I can't imagine an evolutionary thing with the human species that would allow you to permanently damage your metabolism. Now you can damage an organ. If you overdose on Tylenol, you can permanently damage your liver. So we know, and then some of that damage can never be recovered. If you eat too many carbs for too many years, you can permanently damage your kidneys. No doubt about that, right? But to just a style of eating, and I hear this in the community, I know what you're talking about. Oh, you could break your metabolism or permanently damage your metabolism. I don't see any evolutionary or biochemical reason why they would think that's possible. I don't know where they got that concept. John might know, but yeah, I think there's zero credibility to that.
The only thing I would add to that is you did mention 800 calories. So, right, 800 to 1,000. I personally eat once a day, usually 5 days out of the week. My metabolism is pretty good, so I'm doing okay. But when I eat, I'm talking about 3,000 calories. So in terms of metabolism, if you are restricting your calories to that degree, a couple things are going to happen. So when we look at metabolism, what does that actually mean? That means, what do you need just to have your body do its normal function? The difference between doing intermittent fasting or extended fasting and doing calorie restriction, which is essentially, you're doing kind of a double whammy where you're doing calorie restriction and intermittent fasting, and you're going to probably feel miserable. What's going to happen is when you do intermittent fasting, your body switches over mainly to burning fat. So fatty acids from your own fat stores. That's what we want. When you're doing more of a caloric restriction, you're going to start burning protein, lean body mass. And so when we talk about metabolism going down, it does go down with caloric restriction. It can go down as much as 30%. And that is because my thyroid got out of whack. And that can happen if you're calorically restricted. if you're doing keto but you're maintaining your caloric intake, that's not going to happen. And so those two things, I think, is really what people are talking about when they're talking about metabolism and your metabolism being slow. In terms of caloric restriction, most other diets out there, I don't care if it's the latest juice fad, if it's, the colonic versions or whatever people are doing out there, the real goal is they're trying to do calorie reduction. And so if you've done diets in the past, which I'm sure a lot of people have, in general, those diets were restrict your caloric intake to some degree, to massive degrees. Drink 3 shakes a day, eat a sensible meal at night, which I don't know how anybody could do that on those shakes. And the whole point is that if you reduce your caloric intake, you're basically going to lose weight. And well, what happens? Initially, you'll lose weight because you're going to burn glycogen, water. You're going to pee out a lot of weight. You might lose a little bit in terms of lean body mass. Initially, you might lose a little bit of your own fat stores. You're going to be hungry. You're going to be tired. You're going to be cranky. You're going to be starving. You're going to want carbohydrates. And so what have you done? You basically slowed your metabolism by burning through your own lean body mass. Go back and you start eating again because you feel virtuous, because you lost 10 pounds or 15 pounds, or your brain is telling you, I'm starving, I need to eat something. And then you put on 50 pounds real quick. And that 50 pounds is not muscle, it's fat. And what happens to your metabolism? It doesn't go back up to what it was. So now you're dealing with a situation where you put back more weight on, your metabolism is indeed slower, and then you go back through that same cycle, and that's basically the yo-yo diet. Yes?
So my question is, what would be your opinion on splitting that one large meal a day that you have? Because it doesn't work into my schedule as easily because I work out really hard in the morning. So, but I respect that, and I actually have tried that. Just doesn't seem to work for me. I'm also trying to cut back on my bulletproof coffee because it seems as though it's a little bit of an addiction for me, and I'm trying to fight all my addictions all at one time. Okay, so my question is, I divide that meal into 2 meals, and have one earlier in the day and one 3 or 4 hours before bedtime. Could you give me your input on that, please?
With the goal just being to maintain weight?
Yeah.
Okay, so the question was, I mentioned that I do more 24-hour fasts. Can you split that up into 2 meals or 3 meals? 1 in the morning, 1 in the evening? Absolutely, yeah. For me, I do a lot of self-experiment coffee in the morning with a little bit of MCT and some butter. So it's not a strict 24 hours. But the reason that I do it is because I feel better. So I feel sharper, I have higher levels of ketones, I'm in ketosis, I have more energy, I don't feel tired, and I don't have to think. I have a pretty packed day most days, and I usually do it Monday through Friday. So that my day is basically, I'm focused on work, focused on kids, what I need to do. And then when I eat, I have the pleasure of eating with my family. So I can do that. But in terms of looking at, if your goal is, let's say, weight loss, which for a lot of people I think it is, there are studies that look at timing of food is extremely important. One of the benefits of intermittent fasting is that you are allowing a window where your body is basically not taking in energy. And when that happens, you can actually burn your own fat stores, you can suppress your insulin, all the things that I talk about. Whether that is within a 6-hour window, 8-hour window, 10-hour window, I think the goal really is to pick a window that works for you. And so for you, if that is, I work out and post-workout, I need to eat something or else I'm, hard to deal with throughout the day or it's hard for me, that's great. Eating post-workout is actually fantastic because you're actually going to use that energy preferentially. So you're not going to get massive glucose spikes, you're not going to get insulin spikes. And if anything, you're going to burn through that energy much faster. Some people would argue that you should eat your first meal or your big meal in the morning because you're going to use that energy throughout the day. Marty Kendall, who is online and has great information, would make that argument. So I think really figuring out what works for you within the context, but trying to pick a window where you're not eating all day, every day, causing that insulin to be constantly elevated. That's the goal.
Yeah, I totally agree. And if your goal is maintenance, you like where you are, you feel good, everything's great, then I think what you're doing is perfect. If you start to gain a little weight, you want to lose a little weight, then I might still eat the 2 meals, but get them closer together so that you have more total hours of fasting, so that your insulin level stays as low normal as
I
possible for
probably need to do that.
as many hours a day as possible. And but otherwise, if you're happy with where you are, I think that's a great plan. Yeah. Yes.
So some people talk about the 1 meal a day, some people talk about eating until you're full, and then some people talk about eating 2,000 calories like throughout the day or all at one time. Like, how do you know? It gets confusing because I can't. If I waited to eat until I was hungry, I would probably eat 1 meal a day. But if I eat till I'm full, I'm not eating 2,000 calories at that 1 meal. So like, where is the balance here? Because it's very confusing.
Yeah, that's a great question. So, is this on?
Nope.
Leah? Diet. Okay. I can still hold it.
Now you do got to yell.
The battery's probably been up.
Okay, and so the question is, should I do 1 meal a day or 2 meals a day? If I do 1 meal, how am I gonna get enough calories? And so I would say that for most people, if you're just starting, I wouldn't worry about 1 meal a day. That's something, I didn't start there. You start there, that's something you normally naturally progress to. As you do more and more, and eat, very high healthy fats, very low carbs, you just tend to migrate. And so the first thing you tend to drop is 3 meals a day. You just tend to stop having it. You forget to eat, or you're just like, I'm not even hungry. It's dumb to eat if I'm not hungry. And then for some people, that the 2 meals a day, that's where they stay. Like where you're at right now, right? And for other people, as they continue to do this, either they stall and they can't make any more progress with 2 meals a day, or they're eating so much healthy fat that they're just not hungry. And so that second meal a day just kind of gradually goes away. And you're left with 1 meal a day. And I think people who are very busy during the workday, it's really nice to just not even have to worry about eating. I just sip on my butter coffee and have your NCT butter coffee, and I'm running and gunning with the clinic. I don't even think about eating.
So you're not worried about how many calories you're consuming at that 1 meal, as long as you're not feeling physically hungry.
Right, I never count calories. I just eat until I'm full. That's what I do. But that, for me, I would say that's somewhere, it's probably between 2,000, 3,000 calories a day. That's where I typically wind up at, but I would have to track, and I don't track. I can't do that. My ADD won't let me.
One quick kind of tip would be to meal prep. So a lot of times what I'll do is for the week, Sunday will be meal prep week or day. And because we have 5 in our family, we have to cook a lot. And so we will cook the food for the week, most of the week, and then freeze it. So big glass kind of containers in the freezer, so you can portion out what you're going to eat. Initially, when you're starting off, I mean, I agree with Ken. I don't count calories. I'm giving you an estimate of what I think I'm consuming. I would have no idea at this point. But initially, when you're starting out, I think it's important to kind of have an idea of the ratios you're using plus how much you're consuming. Because I guarantee you, if you're starting off this way and you're going to say, oh, I'm just going to eat once a day, when you eat, you're going to be eating a lot more than 2,000, 3,000 calories. So you want to, I wouldn't recommend that most people start off with just 1 meal a day. I would say exactly like Ken said, concise in terms of the time frame that you're eating is very important. Eating until you're full, but initially when you're starting off, it's hard to remember what it means to feel full. One of the beauties of keto and low carb is you start remembering kind of that sensation of, oh, I'm hungry now, I should eat. Oh, I'm full now. And it takes a while to understand what those signals are. So initially, I think it's a good idea to at least have some idea of how much you're going to consume. And then as you get used to it and progress, then you can kind of figure out what works the best for you.
So how do you figure out how many calories you should eat in a day? I feel like that's kind of much.
I wouldn't focus on calories initially. Yeah, keep the carbs low. Make sure you're eating whole foods. Try to get your fats from whole foods. Don't do necessarily the bulletproof coffee all day, every day. eat till you're full.
If a patient of yours has goiters in their thyroid, are there any additional tests that you would run at that point to see if there's an issue? Or do you just
Beyond-
check to see if they get bigger or if there's any change in them?
So the question is, if a person has a goiter, do you check any other tests? So I would do an ultrasound, thyroid ultrasound at least. We mentioned some of the thyroid tests that we described. Ken and I did a Facebook Live on iodine deficiency. So look over at his page. We discuss all the things that cause iodine deficiency. That would be probably the number one reason for somebody to have a goiter. It's pretty rare at this point, unless you're in certain areas that have severe nutritional deficiencies. That's what I would start with. Back.
Hi, just wanted to ask, me and my wife both work out a lot, and we've noticed that with the keto diet, we get a lot of hot flashes, but especially after we work out, if we do a really hard workout, we'll come home, take a cold shower, and then when we're getting ready to go out, all of a sudden we'll start sweating profusely. So I was just wondering if there was any preventative, whether we're missing out on something, or yeah, it will happen at night sometimes too.
Where do you live?
Toronto.
It's not the weather.
Well, we spent a lot of time in Florida too, but I mean,
Maybe it's the Florida weather.
yeah.
Jimmy, any thoughts? I'm trying to think if it's related.
I'm sorry, I
The
was,
question was, they work out a lot, they do keto, they notice hot flashes quite a bit.
I know from me, since I've had my hysterectomy, the ovaries obviously are not there to produce the estrogen anymore, and so that's left in my adrenal glands now, so I don't know if it's the same type of mechanism with the hot flashes with that. So could it be an adrenal issue?
you stumped the panel.
Can I call a friend?
So
I would, I don't want to say 100%, but I do not think that they are correlated.
okay.
I actually haven't heard that talked about a lot. I haven't had a lot of people have that. Have you guys had your gender hormones checked?
Not me, no.
Well, I went on HRT, I came off it. That was not one of the issues that I had beforehand. So I don't think coming off the HRT has affected the only thing I noticed is that I can't sleep. That's the only concern of this. But I did read somewhere, and I can't remember where, that it was thermogenesis or something. It was the burning of fat or burning of energy that causes hot flashes, because it's intermittent all day, all night. It just comes and goes.
Yeah.
Age thing, you think?
So she heard that it was a thermogenic effect from burning the fat, but it's off and on. It's like in spells through the
Yeah.
day.
Yeah.
Yeah, that sure sounds hormonal to me.
Yeah.
Sure does.
He's having sympathetic hot flashes.
Yeah, maybe.
Nice cry.
I don't know if it's after a meal, like an hour after a meal, they
Oh,
can
it's-
have a fair amount of protein in it.
It's sporadic, I mean, yeah.
To me, it's always after I work out.
Are you
Yeah.
doing intervals, or are you doing weights, or
Could be, it could be weights, or it could be a hard run.
So
Could
it
be,
doesn't matter what
what's that?
it doesn't matter the type of workout it is.
No, if it's a very, very hard workout, as
And then you
opposed
have
to,
a rest period, then you feel hot later.
yeah,
Like after you've recovered.
I can work out and when I go take a cold shower, and then when I'm getting ready to go out, then all of a sudden I'll start sweating profusely again. Happens to her too, so I was just wondering.
Yeah.
That seems to be happening a lot, well, really since I started doing the keto diet.
Okay.
So I'm just
I
wondering.
mean, it could be, you're raising your core temperature to some degree by doing that.
Somebody wrote vasodilated or something.
It could very well be it, when I'm out in the sun a lot in Florida, like when I take a shower and 20 minutes later, I'm sweating.
Yeah, it could be just more of a core temperature issue.
Yeah.
How it relates to keto though,
No.
I don't think so.
Okay.
Ice bath.
Yeah, that's right. Yes, ma'am.
My question is kind of the opposite of that.
Yes.
After being on keto and freezing to death all the time, this room doesn't have that problem. Find that be true a lot about the cold all the time.
That's probably the more common symptom that we hear about is I feel cold. I have difficulty regulating that. How long have you been doing keto?
A year and a half.
Okay. And what's kind of your normal day-to-day food intake? What's your normal day-to-day food intake? Are you eating one meal a day, 2 meals a day?
Usually 2, but 3 sometimes.
Okay. Are you restricting carbohydrates
Yes,
to what number in general?
20 or lower.
Okay. And
But she just whispered, she says, but you don't have thyroid.
oh,
But
okay.
I
Do you take thyroid replacement?
do, but
Okay.
I wasn't freezing until the keto.
Right. Yeah. Sometimes. Are you doing a caloric restriction with it?
I don't pay attention.
But I mean, do you feel like you're
Oh, yeah,
okay?
but I don't track.
Yeah. A lot of times it's not so much keto per se; it's the caloric restriction. That's the biggest issue, and that sometimes can happen because you feel so full. And so remembering to eat or thinking in terms of how many calories you're consuming, and I find that tends to be more likely the cause, not necessarily keto, but just more of a caloric restriction. Especially if you're on thyroid replacement as well, have you had your thyroid levels rechecked?
Yeah, just the day before.
And was it normal?
It was 0.5. That's supposed to be
Okay.
really low.
Yeah. Okay.
Surprised.
I forget which replacement are you taking?
I'm 11 thyroid.
Okay, so again, that's fake T4, right? That's not real T4. And so, 2 things I would say for you, it's probably calorie restriction, and you're probably not doing it on purpose. But when you calorie restrict, you can actually lower your metabolic rate. And one of the ways your body does that is by lowering your basal temperature by up to half a degree. And so that'll tend to make you cold a lot. If you don't have any good sources of iodine in your body, that's a huge deal. I can tell you, Nisha, when we first met, she was so cold-natured that the hardwood floor without socks would literally cause pain. She was so iodine deficient. And now with her two or 3 drops of Lugol's every day, she's not like that at all. That's completely gone. And so I would really look into an iodine replacement. If you have normal kidney function, you're not going to take too much iodine, although some doctors freak out about that big time. 1 or 2 drops of 2% Lugol's once a day, that might be the solution for your coldness. And then also I would try to get on Nature or Armor thyroid.
Does the doctor have to prescribe that?
Yes. Not the iodine, but the thyroid replacement,
And it's
yes.
called Nature.
Nature Throid or Armor thyroid.
Just name takes armor.
Yeah. And anybody who has thyroid issues, Gorders, hypothyroid, there's a website called Stop the Thyroid Madness. If you read for, both of them, right? Yeah. And I love the website. I've got the book, but I don't love it so much. But the website is amazing. And if you read on that website for 2 hours, you'll be smarter than the average doctor about thyroid.
And another one, Dr. Davis Karasi, is another huge thyroid guy who came up. It's a hard name to spell, just try it.
But make sure you're not calorie restricting accidentally. Get some iodine and see if you can't change to Nature or Armor. And I predict you will not remember where you put that sweater.
All right, guys, we're fresh out of time for the medical panel. So let's take a break here and